So our basic motto was to cover the long cases at first, along with the long questions which are commonly given in your MS examination. So for that purpose, we are going with the discussion of a long case of the thyroid swelling, which is often given as a long case in your final MS examination. So while dealing with a long case, it will get 100 marks in your examination. And a part will be given for the detailed discussion regarding the history. A part will be there for the discussion regarding the clinical steps, and another part for the academic discussion regarding the management part, and obviously regarding the surgical approach. So first we have to start with the history of a long case of the thyroid swelling. For the discussion, I will suggest you to open your audio so that you convert it into a bilateral discussion. So please turn on your audio, please. So anyone, just tell me what will be the chief complaint for any thyroid swelling like this patient. She has got a swelling in the front of the neck, particularly on the right side. Other than this, she is mostly asymptomatic. So on the basis of this clue, what would be the clinical feature for this patient? Anyone just tell me what would be the clinical features? The history of present illness.
So it would be a long-standing swelling in the center of the neck, which she noticed.
While you were describing the term long-standing, while you were describing the term long-standing, you should be very much specific regarding the duration. Would it be for the 6 months or 1 year or 2 years or something like that? So when describing, just be specific how long the swelling is present and in which anatomical site the swelling is present. So precisely give us such a clue how long the swelling is present and in which part of the neck. The anterior part of the neck on the right side or both the sides of the neck anterior. Okay, so just tell me, just chief complaint. She is otherwise absolutely asymptomatic.
So the patient will present with, she will complain that she has recently observed a swelling in the front of her neck few days back while she was doing some household chore or while she was bathing.
That is coming under the discussion of the history of present illness.
Okay.
First, you have to tell the chief complaint only. So in that
swelling in the anterior neck, swelling in the.
Okay, it would be a better option that Mrs. X or Mr. Y, a Hindu, Muslim or Christian, male or female, aged around 40 years, was admitted in this hospital on day of admission and is examined today, who was presented with a painful or painless swelling in the front and right side of the neck for the last 6 months. So Mr. X or Mrs. X, a Hindu, Muslim or Christian, male or female, around 40 years of age, coming from a middle class or poor socioeconomic family of that particular region, habituated with average Indian diet, was admitted in this hospital on day of admission and is examined today, who was presented with a painless, progressively increasing swelling in the front and on the right side of the neck for the last 6 months. With that, we have to go for the history of the present illness. Okay. So for describing any long case, whatever be the anatomical site, whatever be the final diagnosis, ideally you should approach or you should start your history of present illness in such a way so that the basic identification should be included in the history of present illness so that you can identify the patient. Next will be the history of present illness. For thyroid swelling, what are the classical points that should be focused in history of present illness? See, thyroid gland, there is a swelling. It could be a goiter or it could be a solitary thyroid nodule. So one is a swelling that should be incorporated in the history of present illness. The description of any kind of swelling, that is size, shape, surface, margin, how long the swelling is present, how rapidly the swelling is increasing in size, that will be included in the first step. Second is, as neck is a very narrow structure, so there could be some features due to compression of the underlying structures. So we have to keep it in mind, there are at least 3 underlying structures. One is the recurrent laryngeal nerve, one is the trachea, and one is the esophagus, that the patient could have clinical features because of the compression. So you have to narrate the same, either presence or absence, in the language of the patient herself. There is recent change in the quality of voice, not the hoarseness. Second one is the painful deglutition or painful swallowing of the food. And third one is the respiratory distress. If the patient is having the same, how long the patient is having the same scenario, or absence of such clinical features. That means the swelling, whatever be the size, the patient doesn't have any features due to the compression of the underlying structures. Thirdly, you have to describe the presence or absence of biochemical alteration of the thyroid function. That is, whether the patient is in the state of the euthyroid or thyrotoxic or hypothyroid. And you have to describe the same in a systemic way. So anyone just tell me what could be the clinical features in the way of the systemic manifestation so that we can tell the patient is in the euthyroid state or hypothyroid state or in the state of the thyrotoxicosis. Anyone, please give me some clue.
Sir, depending on the whether the patient is hypo or hyperthyroid. If the patient is hypothyroid, she will have complaints of weight gain, easy fatigability, menstrual abnormalities like any kind of menorrhagia or hypomenorrhea, and apart from that, she will also complain of.
So if you don't mind, may I interrupt you? Ideally, you should describe it in a proper systemic way.
Yes, sir.
So any patient could have the clinical features regarding the thyrotoxicosis or hypothyroidism, or the patient may be in the euthyroid stage, depending on the systemic manifestations that should be discussed in a proper systemic way. So first start with the higher function. Ideally, the patient should be alert, fully alert, conscious and cooperative. But in the contrary, if the patient is lethargic, drowsy, it focuses more in the state of the hypothyroidism. Or else if the patient is restless or irritated, or in favor of the thyrotoxicosis. So first one is the higher function. Second one is alteration of the sleep cycle. If the patient is having a profound period of the sleepiness, more in favor of the hypothyroidism. On the contrary, if insomnia is there, patient is likely to be in the state of the toxicosis. So absence of all these two clinical features, from the point of view of the higher function, it indicates the patient is in the state of the clinically euthyroid on the basis of these two higher functions. So always start from the higher function, mention the points whether the patient is alert, conscious and cooperative, neither in the state of the drowsiness, lethargy, nor in the state of the restlessness, irritability, without any alteration of the sleep cycle, either in the form of the increased sleepiness or insomnia. The patient is clinically on the basis of the higher function in the euthyroid state. So first clinical feature is finished. Now we move to the lower part. So start from the eyes. What could be the clinical features regarding the eyesights? What the patient can tell of? Only few features. First is forward bulging of the eyeballs, which the patient can also narrate. So any evidence of forward bulging of the eyeballs closely relates to the toxicosis. Second one is blurring of vision, doubling of vision, and ultimately loss of vision, which always indicates the patient is in the state of the critical or severe thyrotoxicosis. So first one is the higher function, second one is the eye functions, which the patient may have in your history, or else you have to narrate it in the form of the presence or absence of the history of present illness, so that you can document from your history the patient is in the state of the euthyroid or hypothyroid or toxicosis. So regarding the eye signs, what the patient will tell of forward bulging of the eyeballs, second is blurring of vision, third one is doubling of vision, and finally the total loss of the vision. So number one, number 2 points are finished. Now move on to the facial expression. Patient, particularly an intelligent patient, may also complain of prominence of the facial veins and the neck veins, which clearly indicates there is a chance for the retrosternal extension of the thyroid swelling. So while you're taking the history, you should ask the patient if there is an evidence of prominence of the facial veins and the neck veins, which clearly indicates there is a chance for the retrosternal extension of the goiter. Now move on to the chest, the precordium and the lungs. What the patient will complain of if there is any history of hypothyroidism or thyrotoxicosis from the cardiovascular point of view. What the patient will complain of? Anyone please?
So the patient will mainly complain of palpitations.
Anything else?
If she is having features of thyrotoxicosis.
Okay, anything more? Anyone? Anything more? Obviously, the patient will start the complaining of palpitation. With palpitation, with ongoing thyrotoxicosis, there will be exertional chest pain and exertional dyspnea. So on one hand, patient will initially complain of palpitation, followed by exertional chest pain and exertional dyspnea or respiratory distress, all because of the thyrotoxicosis. We will have the explanation a bit later on. On the contrary, if the patient is having hypothyroidism, patient will again complain of respiratory distress. I will give the explanation a bit later. Just keep it in your mind. From the point of view of the precordia, there are two systems. One is the cardiovascular, another one is the pulmonary system. In thyrotoxicosis, patient will complain of palpitation followed by exertional chest pain and exertional respiratory distress if the patient is thyrotoxic. Or else if the patient is hypothyroid, patient will also complain of respiratory distress. We will have the discussion later on. Just keep it in your mind. Now move on to the abdomen, the upper GI and the lower GI. What will be the clinical features in upper GI if the patient is thyrotoxic or if the patient is hypothyroid? Anyone? If the patient is having a thyrotoxicosis, the upper GI feature will be increased appetite but significant loss of the body weight. And in the contrary, if the patient is hypothyroid, the patient will complain of decreased appetite but significant increase in the body weight. So far as the upper GI is concerned, patient will complain of increased appetite but significant loss in the body weight if the patient is thyrotoxic. On the contrary, if the patient is hypothyroid, patient will complain of decrease in appetite but at the same time significant rise in the body weight. Now move on to the lower GI or the colonic system. In hypothyroidism, the patient will complain of constipation, and in the contrary, if the patient is toxicosis, the patient will complain of diarrhea. Now regarding the pelvic organ of the female patient, in both hypothyroidism and in thyrotoxicosis, there is the chance for the recurrent spontaneous first trimester abortion. So in female patient, that too in the childbearing age, if the patient is hypothyroid or thyrotoxicosis, patient will complain of recurrent episodes of spontaneous first trimester abortion. And at the same time, if the patient is hypothyroid, patient will complain of menorrhagia, and if the patient is thyrotoxic, the patient will complain of oligomenorrhea or even hypomenorrhea. So systemically, if we proceed to the abdominal part, we will divide it into three organs. One is the upper GI, one is lower GI, and the pelvic organs. In the upper GI, what will be the clinical features? If the patient is hypothyroid, there will be decreased appetite, but there will be significant increase in the body weight. If the patient is thyrotoxic, patient will have lowering of the appetite, increased appetite, but significant drop in the body weight. So far as the colon is concerned, in hypothyroid, we will get constipation, and in thyrotoxic, patient will complain of diarrhea. For the female individual, that too in the childbearing age, the patient will complain of recurrent episodes of first trimester spontaneous abortion. Along with that, in hypothyroidism, patient will complain of menorrhagia, and in thyrotoxicosis, patient will complain of oligomenorrhea or hypomenorrhea. And finally, regarding the peripheral extremity, the patient may also complain of fine movement of the fingers because of the tremor. So all these clinical features you have to narrate into your history of present illness so that you can stamp the case as the patient is either in the state of the euthyroid, hypothyroid, or thyrotoxicosis. So while you are describing any patient of having a solitary thyroid nodule or goiter, you have to describe your history of present illness in a systemic way so that the three rational points must be touched. One is the description of the swelling as a whole. Second one, if there is any evidence of the compression of the underlying structures. And third, the patient is having any biochemical alteration of the thyroid function, so that you have to mention the patient in the euthyroid state or hypothyroid state or in the state of the thyrotoxicosis. So any confusion regarding the chief complaint or history of present illness, or else we will proceed for the general survey. Any confusion or any query regarding history of present illness or chief complaint?
Sir, if pain is there, will we describe pain also in the present illness history?
Obviously, if the patient is having any kind of pain, that should be included.
Will we describe it in proper way, like the character of pain and whether it's radiating?
Yeah, obviously. The classical features of the pain, mode of onset, nature of the pain, the precipitating factor, the reducing factor, any aggravating factor, any radiation or any referral. However, in most of the cases, you will not get any patient of thyroid swelling with the pain.
Another thing is
swelling only.
The history of present illness, if patient like
something of pain.
Sir, okay, sir. Sir, another thing is that if patient patient is presenting with many complaints, like first of all, he describes that he's having like tremors or something like that, and not coming forward with the swelling as a chief complaint. So will we like write it in the way patient is describing us in the history of present illness, or we'll start from that swelling only?
If the patient is complaining of any particular clinical feature, that should be included in your history of present illness and also in the chief complaint. So, if the patient is having a tremor only along with the swelling, and if the patient is complaining of tremor, that should be given the first priority, and the second priority will be also the thyroid swelling. But in the history of present illness, the positive features should be enlightened at first, then you have to rule out the negative features.
Okay, sir.
Yeah?
Okay, sir.
Okay. So, can we now proceed into the general survey? So now tell me, first is general survey. What is the importance for assessment of the general survey? It will give you the clue again whether the patient is having any evidence of thyrotoxicosis or hypothyroidism, or else the patient is having some underlying pathology which is not directly related to the process of the disease, but may interfere with the surgical outcome or may interfere with the anesthetic fitness. So here lies the importance for assessment of the general survey. So start with the higher function. So now you tell me what will be the description of the higher function. Anyone just tell me what will be the description in higher function, and you have to correlate with the thyroid swelling. Anyone please. Anybody just tell me what will be the description regarding higher function and how you can correlate with the thyroid swelling. Anyone just tell me.
Sir, as per usual, we'll start by commenting on the current status of the patient, whether she is conscious, alert, and cooperative and well-oriented to time, place, and person during examination. And if there is any kind... Yes, sir.
Yeah, proceed, please.
Sir,
So
then
if
we
you are
should...
telling the patient is alert, conscious, and cooperative with proper orientation of the time, place, and person in the background of the thyroid swelling, you directly delineate that the patient is likely to be in the thyroid state.
Yes, sir.
So in the background of a thyroid swelling, while you are describing the patient is alert, conscious, and cooperative, and properly oriented in respect of the time, place, and person, it indicates that the patient is in the euthyroid state. Or this the patient could be drowsy, lethargic, that focuses in patient in presence of the hypothyroid state, or if the patient is restless or irritated while assessing the higher function, the
Or
patient is likely to be in the
anxious,
thyroid
anxiety is also
anxiety, restlessness. So it indicates the patient is clinically on this basis of this finding in the thyrotoxic state. So while you are describing the higher function and while you are describing the patient is alert, conscious, and cooperative with properly oriented, patient is likely to be euthyroid. Second possibility, patient is drowsy, lethargic, likely hypothyroid. Third possibility, patient is restless, irritated, nervous, not properly oriented, likely to be in the thyrotoxic state. So on that basis of the higher function assessment, you can have an idea regarding the biochemical features of the thyroid swelling. Clear? Next is build followed by nutrition. What do you mean by build and what do you mean by nutrition? Anyone just tell me in a very fine way, not a detailed discussion or elaboration. Just tell me what do you mean by build and what do you mean by the nutrition. Anyone just tell me. Anyone just tell me what do you mean by build and what do you mean by nutrition? Okay. The skeletal framework of the patient is simply the build. The skeletal framework of the patient is simply known as the build. So the next question will be, If you get a patient with a thyroid swelling, with dwarfism, what is the direct relationship? Again, the same question, you have got a patient who is dwarf along with a thyroid swelling. So what are the patient is suffering from? What is your suspicion?
Congenital hypothyroidism.
Or that is also better to say it as cretinism.
Cretinism.
So if you get a patient who is having dwarfism along with the swelling in the thyroid gland, clinically the patient is likely to be suffering from congenital hypothyroidism or cretinism. So here lies the importance of the build while you are assessing any thyroid swelling. So average build, we can rule out congenital hypothyroidism. Dwarfism along with the thyroid swelling, likely to be the presence of congenital hypothyroidism or cretinism. Second one is the assessment of the nutritional status. At bedside, what are the clinical steps for assessment of the nutritional status? All of you, I think, know. Just tell me the basic 3 steps for assessment of the nutritional status.
First BMI can be BMI.
Yes. First is body mass index. Second one,
skin fold thickness can be
skin fold thickness.
Over triceps.
Third one,
Mid upper arm circumference.
Mid upper arm circumference at the level of the triceps. Now, just tell me from your previous discussion regarding history of present illness, if the patient is having a low body mass index with a thyroid swelling, what will be your interference? Question is very straightforward. You got a patient of thyroid swelling along with a low body mass index. What will be your take-home message?
Hyperthyroidism can be there. Hyperthyroidism.
So, hyperthyroidism, or better to say, patient is suffering from thyrotoxicosis. That's why the patient is having a low body mass index. So, on the basis of gait and nutrition, if the patient is having a low body mass index along with the thyroid swelling, first impression, patient is suffering from thyrotoxicosis. Clear? So 3 points have been narrated. One is the higher function, second one is the build, and third one is the nutrition. Now move on to the anemia, cyanosis, jaundice, clubbing edema. All are very important so far as thyroid swelling is concerned. If you get a patient of thyroid swelling with mild to moderate anemia, what is the correlation between the thyroid swelling or biochemical alteration of the thyroid function and the appearance of the anemia? I think all of you know how to assess the anemia. It's basically a question of the undergraduate student, not discussing here. But you have to know the relationship between thyroid swelling and the presence of mild to moderate anemia. Question is, you got a patient with a thyroid swelling. On general survey, you got the patient is having mild to moderate anemia. What is the direct relationship between a thyroid swelling or biochemical alteration of the thyroid function and the presence of the anemia? Anybody? Okay, let me give the explanation. Thyroid hormone helps in the synthesis and maturation of the transferrin. So what is the role of transferrin? It transports the iron after its absorption to the erythropoietic cells. So if the patient is suffering from hypothyroidism, there will be decrease in the circulating level of the transferrin. So even after proper digestion or absorption, this iron won't be available for deposition into the erythropoietic tissue. So what will be there? The patient will suffer from clinically evident iron deficient anemia. Again, I repeat, thyroid hormone helps in the synthesis and maturation of the transferrin, which helps in the transfer of the digested iron. So if the patient is suffering from hypothyroidism, even after oral ingestion of the iron, this iron won't be able to pass into the erythropoietic tissue. So the patient will suffer from clinically evident iron deficient anemia or clinically evident microcytic hyperchromic anemia. And this anemia classically doesn't respond to the iron replacement therapy. Because if you replace the patient with iron, even after adequate iron therapy, this iron won't be available for circulation. So this is known as iron-resistant microcytic hyperchromic anemia, which selectively responds well to levothyroxine supplementation. So any patient of thyroid swelling, along with the presence of anemia without any precipitating factor, first you have to rule out any hypothyroidism. Because thyroid hormone helps in the synthesis and maturation of the transferrin, which helps in the transfer of the iron into the erythropoietic tissue. So in deficiency of the thyroid hormone or in hypothyroid state, as there is low circulating level of the transferrin, there will be functional transferrin deficiency or functional iron deficiency. So patient will suffer from iron deficient anemia, which doesn't respond to the iron supplementation. That's why it's called iron deficient, iron resistant microcytic hypochromic anemia, which classically responds well to levothyroxine supplementation. Clear? Next one is cyanosis. Just simply forget it. There is no direct relationship between a thyroid swelling and the appearance of the cyanosis. Next is jaundice. Suppose you got a patient again with a thyroid swelling, be it a solitary thyroid nodule or a goiter. While you are assessing for the assessment of the general survey, you get a point, the patient's sclera is a bit yellow. However, on history, the patient doesn't complain of any yellowish discoloration of the urine. The liver function test is absolutely normal. The urine RDMA doesn't show any ureobilinosin in the urine. Only a bit yellowish discoloration of the eyes along with the thyroid swelling. Liver function test is absolutely normal. So also the urine RDMA report and the urine color is also absolutely normal. Only positive finding is mild degree of yellowish discoloration of the sclera along with the thyroid swelling. Could be the relationship?
So due to carotene deposition is there?
Yeah. What will be the steps? Again, the thyroid hormones helps in the metabolism of the retinol. It's a very good source of the vitamin A, which is yellow to orange in color. So retinol is oxidized to form retinal, again oxidized with the help of the thyroid hormone to form the retinoic acid, which is absolutely colorless. So if the patient is hypothyroid, what will happen to the retinol oxidation? More and more retinol will be accumulated in the body. Some will penetrate into the sclera and will give some degree of yellowish discoloration. But it has got no relationship with the bilirubin metabolism, so the liver function test is absolutely normal, so also the urine color. So if you get a patient of thyroid swelling with some degree of yellowish discoloration of the sclera, your take-home message is that patient could have some degree of hypothyroidism. Because thyroid hormone helps in the metabolism of the retinol, and in the absence of the metabolism of the retinol to retinoic acid, which is colorless, more and more retinol is deposited in the body tissue, including some amount of retinol is deposited in the sclera. That accounts for the yellowish discoloration. But it has got no relationship with the bilirubin metabolism, so that the LFT is absolutely normal, so also the urine color. Next one is clubbing. There is no direct relationship, so there is no discussion. Next, we'll come to the point of the edema. Tell me the explanation of presence of pitting edema and non-pitting edema in the background of the thyroid swelling. The discussion between the presence of pitting edema along with the non-pitting edema in the background of the thyroid swelling, and what is the direct relationship? Anybody? Chirantan? I think you are a good person to tell me the answer. Anybody? Sorry, I don't know all of you by name, so anybody could be the volunteer and can give me the answer.
Sir, if there is any fibrous tissue deposition, there can be non-pitting edema. If there is any accumulation. Okay, sir.
Not because of that. Let me explain the same. First, thyroid hormone helps in the maintenance of the plasma osmolarity. So if there is hypothyroidism, what will happen to the plasma osmolarity? Thyroid hormone helps in the maintenance of the plasma osmolarity. So if the patient is suffering from hypothyroidism, what will happen to the plasma osmolarity? Dropping the plasma osmolarity. So for the maintenance of the equilibrium in the plasma osmolarity, more and more fluid will be shifted to the third space. So what do we mean by third space? The subcutaneous space, the pleural space, the pericardial space, and the peritoneal space. The largest one is the subcutaneous space that accounts for the pitting edema. So in presence of the hypothyroidism, as the thyroid hormone helps in the maintenance of the plasma osmolarity, so if the patient is suffering from hypothyroidism, there will be lowering of the plasma osmolarity. So for the maintenance of the equilibrium in the plasma osmolarity, more and more fluid will be shifted from the intravascular space into the interstitial space, including the third space. The common third spaces are the subcutaneous space, including the lower limb, the peritoneal cavity, the pleural space, and the pericardial space. So we'll get a pitching edema in the dependent part of the foot. And that's the reason why the patient could have also pleural effusion and pericardial effusion, and that accounts for the respiratory distress, which we have told in the general survey, when the patient may also have a respiratory distress even in hypothyroidism. Because in hypothyroidism, there will be accumulation of fluid in the peritoneal space, in the pericardial space, and also in the pleural space, leading to pleural effusion that accounts for the respiratory distress even when the patient is hypothyroid. So here is the reason when you can get a pitting edema in presence of hypothyroidism. And non-pitting edema, you all know it because of the mixed edema. So in the background of the thyroid swelling, if you get a pitting edema, that accounts for the hypothyroidism, which is responsible for the maintenance of the plasma osmolarity, and you get the pitting edema. Again, in hypothyroidism, you can get also a non-pitting edema, that is the mixed edema. So both are clinically possible in the same patient at the same time. So one part is finished, that is the anemia, cyanosis, jaundice, clubbing, and the edema. Now move on to the pulse, temperature, respiration, and the blood pressure.
Sir, excuse me, sir. What is the cause of non-pitting edema?
Actually, there is some degree of alteration of the tissue regeneration and tissue fibrosis. So in hypothyroidism, there will be alteration in the tissue regeneration and the fibrosis. So the vascular integrity is lost, and some amount of fluid is deposited in the subcutaneous layer, being interposed by the non-healing of the fibrous tissue. So even you press the swelling at the dependent part of the foot, because of the underlying tissue which is not properly regenerated, the pitching nature of the edema is lost. Actually, this is also a pitching edema, but this is lined by a non-degenerated fibrous tissue, so that the pitching nature of the fluid is gone, and we get the non-pitching edema. Okay.
Thank you, sir. Yes, sir. Thank you, sir.
Now move on to the second. Okay. Now move on to the second part of the general survey: the pulse, temperature, respiration, blood pressure. So first, start with the pulse. You tell me what will be the findings if the patient is euthyroid, hypothyroid, or thyrotoxic. Anyone, please. If the patient is hypothyroid, one only feature is sinus bradycardia, nothing more than that. So if the patient is hypothyroid, only clinical finding is patient is suffering from sinus bradycardia or a pulse rate less than 60.
Sir,
Now,
चल रहा है सर बाकी तो किसी को पूछिए
am I audible now?
हाँ आ रहा है सर गुड टू गो सर
Can I start now? Audible? Okay. So what will happen in case of thyrotoxicosis? Stage 1, there will be sinus tachycardia or a pulse rate of more than 80 to 100 per minute, but the rhythm is still regular. Now stage 2, there will be atrial fibrillation in the form of irregular pulse. Stage 3 will get atrial flutter when you will get the regularly irregular pulse. And the final stage, that is the stage 4, some of this supraventricular tachyarrhythmia or atrial tachyarrhythmic waves will bypass the atrioventricular node, and now the ventricle will get this ectopic beats, producing left ventricular ectopic focus, which will be manifested as drop beat. So these are the classical features of pulse, which you will get either in the hypothyroidism or in the thyroid state. So these are the classical features. Now, in addition to that, you have to know the special character of a pulse, that is the water hammer pulse or the high volume collapsing pulse, which is a classical feature of the thyrotoxicosis. Now, anyone tell me what are the basic pathogenesis regarding the water hammer pulse or the high volume collapsing pulse? Anybody just tell me what is the basic pathogenesis regarding the water hammer pulse or the high volume collapsing pulse, which is a hallmark for the thyroid oxycosis? Anyone, just tell me. Anybody? Okay. There are 6 to 7 reasons for the water hammer pulse or the high volume collapsing pulse. For each of them, there will be a white pulse pressure. So what do you mean by pulse pressure? The difference between the systolic and the diastolic pressure. So for getting a white volume pulse, either the systolic BP should be raised or there must be concomitant drop in the diastolic blood pressure so that the pulse pressure is increased. So in thyroid oxycosis, what will happen to the systolic blood pressure and what will happen to the diastolic blood pressure? So again, you know there is positive inotropic and chronotropic effect. So heart rate is increased, so also the force of contraction. So if the heart rate along with the force of contraction is increased, what will happen to the cardiac output? There will be concomitant increase in the cardiac output. So left ventricle is injecting more amount of blood in a more sustained way to the systemic circulation. So what will happen to the systolic blood pressure? If the cardiac output is raised, the systolic BP is directly proportional to the cardiac output. So there will be sharp increase in the systolic blood pressure. Clear? So once again, giving the explanation, with toxicosis, there will be positive inotropic and positive chronotropic effect. So heart rate will be increased, so also the force of contraction. So if the heart rate and the force of contraction both are increased, there will be sharp increase in the cardiac output. And the systolic BP is directly related to the cardiac output, so there will be sharp elevation of the systolic blood pressure. Now, what will happen to the diastolic BP in presence of thyroid oxycosis? Thyroid hormone at the same time is a calorigenic hormone. It utilizes more amount of glucose as a substrate, producing the glucose oxidation, leading to carbon dioxide and liberation of energy in the form of the heat energy. So if heat energy is liberated during thyroid oxycosis, the core body temperature is increased. If the core body temperature is increased, now the body will yield some counter-regulatory phenomenon by activation of the hypothalamus. The hypothalamus will try to down-regulate the body temperature. So how will it do it? By the form of the sweating. The sweating occurs through the skin. The skin is the largest peripheral organ. So for sweating, there must be cutaneous vasodilation. As there is vasodilation, that too in the skin, which is the largest peripheral organ. So what will happen to the diastolic blood pressure? If there is vasodilation in the skin, there will be sharp drop in the diastolic blood pressure because of the vasodilation. So at the same time, there is sharp elevation of the systolic blood pressure and sharp fall in the diastolic blood pressure. So there will be augmentation of the pulse pressure or white pulse pressure, and the pulse is manifested as high volume collapsing pulse or water hammer pulse. Finally, all of these features are because of the thyroid oxycosis. Only one due to the hypothyroidism. That is the characteristics wall of the radial artery. Normally, we can palpate the pulsation of the radial artery, but the radial artery wall is usually not palpable. When it becomes palpable, when there is thickening of the arterial wall. When there will be thickening of the arterial wall, as there is deposition of the cholesterol in the intima and the lumen of the arterial wall. Now again, thyroid hormone helps in the metabolism of the cholesterol. So in hypothyroidism, there will be less metabolism of the cholesterol. More cholesterol will be available in the circulation to get deposited in the inner lining of the radial artery. So the arterial lumen becomes sclerosed and thickened, and you can palpate a thickened arterial wall. So in the background of the thyroid swelling, if you get a thickened arterial wall, likely because of the hypothyroidism. So from the point of view of the pulse, all the clinical features are because of the thyroid oxycosis, except the thickened atherosclerotic arterial wall, which is a classical feature of the hypothyroidism. So in nutshell, what will be the alteration in the pulse? Red, special character, and third one is the thickening of the arterial wall. Start from the red. Hypothyroidism, sinus bradycardia. Euthyroid, normal pulse. Thyroidoxic, stage 1, sinus tachy. Stage 2, atrial fibrillation. Stage 3, atrial flutter. Stage 4, ectopic beats. Finally, you can get a special character of the pulse, that is the water hammer pulse because of the white pulse pressure again due to the thyrotoxicosis. And only one finding in hypothyroidism, that is the thickened intima of the radial artery, which is a classical feature of the hypercholesterolemia because of the hypothyroidism. Is it clear to all of you regarding the pulse? Second is temperature. Now from this discussion, anybody tell me what will be the clinical feature of the body temperature in presence of hypothyroidism and also in presence of the thyrotoxicosis? Anyone just tell me.
In hypothyroidism, the temperature, body temperature decreases and patient is feeling with cold. In hypothyroidism, due to increase in metabolic rate, the temperature rises and patient is generally having higher body temperature.
So what will happen in presence of hypothyroidism? The body temperature will be less.
Yes.
And there will be peripheral vasoconstriction so that the body temperature can be maintained. So if there is peripheral vasoconstriction, again the patient will have isolated diastolic hypertension, which is a hallmark of hypothyroidism. So if we were assessing the temperature, you have to assess the core body temperature. If the patient is having a low body temperature, likely because of the hypothyroidism. And to maintain the body temperature within the core of the body, there will be intense peripheral vasoconstriction. And in presence of the peripheral vasoconstriction, only there will be isolated diastolic hypertension, which is a hallmark of the hypothyroidism. On the contrary, in presence of thyrotoxicosis, patient will have a rise in the body temperature. So what will happen if you palpate the palm of the finger or you palpate the palmar surface of the patient? What will be the information? In presence of hypothyroidism and back to the case of thyrotoxicosis, while you are assessing the body temperature, if you palpate the palmar surface of the patient just for assessment of the body temperature, what will be the additional findings? In hypothyroidism, there will be peripheral vasoconstriction, so less sweating. So there will be lowering of the body temperature, and because of the less sweating, it will be dry in nature. So cold and dry palmar surface in case of hypothyroidism, and simply the opposite, that is warm and moist in case of thyrotoxicosis. What's the reason? You know the reason behind the low body temperature. So extremity will be cold in case of hypothyroidism, and because of the peripheral vasoconstriction, there will be less sweating in case of hypothyroidism. So we'll get cold and dry peripheral extremity in case of hypothyroidism, and simply the reverse, that is warm and moist peripheral extremity in case of thyrotoxicosis. So another point is pulse, then temperature. Now move on to the respiration.
More amount of glucose metabolism in hypothyroidism হচ্ছে যার কারণে স্যার অক্সিডেশন অফ হচ্ছে কার্বন ডাই অক্সাইড প্রডিউস করছে পেরিফেরাল ভ্যাসোডাইলেশন হচ্ছে হাইপোথ্যালামাস অ্যাক্টিভেটেড হচ্ছে পেরিফেরাল ভ্যাসোডাইলেশন হয়ে সুইটিং হচ্ছে সো এটা হচ্ছে হাইপোথাইরয়েডিজমের ক্যারেক্টারিস্টিক হচ্ছে এখানটায় স্যার যদি আমাদের মানে হাইপোথাইরয়েডিজম টেম্পারেচারের ক্ষেত্রে পেরিফেরাল ভ্যাসোকনস্ট্রিকশন যেহেতু টেম্পারেচার কমছে পেরিফেরাল ভ্যাসোডাইলেশন হচ্ছে আইসোলেটেড ডায়াস্টোলিক ব্লাড প্রেসার বাড়ছে সেক্ষেত্রে সেটা পেরিফেরাল ভ্যাসোডাইলেশন হচ্ছে মানে তো সুইটিং হওয়ার কথা হচ্ছে হাইপোথাইরয়েডিজমের সুইটিং স্যার
হাইপারে পরে পুরো এখানে শেষ করে পরে আমি চলে বলে দিচ্ছি নাও মুভ অন টু দ্য respiration. What will be your findings on respiration if the patient is hypothyroid and your respiratory findings if the patient is thyrotoxic? Some degree of discussion has already been done. From your knowledge, you just tell me what will be the respiration in case of hypothyroidism. The clue is that some amount of fluid is there in the pleural space as also in the pericardial space. So what will be the respiration rate? You already know, because of the change in the osmolarity, because of the hypothyroidism, body fluid will get migrated into the third space, including the pericardial space and the pleural space. So there will be pleural effusion and the pericardial effusion. So in hypothyroidism, we will get the tachypnea because of the pleural effusion and pericardial effusion. Secondary, due to the lowering of the plasma osmolarity, there will be shifting of the fluid. So we'll get tachypnea in case of hypothyroidism because of the pleural effusion. Now, what will happen to the respiratory rate if the patient is suffering from the thyrotoxicosis? What will happen? The patient will also complain of respiratory distress or tachypnea in presence of thyroid oxidosis. What's the reason? You have already told that in thyroid oxidosis, more glucose is utilized as substrate. So what will be the end product? The energy along with the carbon dioxide. So if the circulating level of carbon dioxide is raised because of the thyroid oxidosis, this carbon dioxide will stimulate the respiratory center and so there will be tachypnea. So you can get tachypnea both in hypothyroidism, also in thyroid oxidosis. Why in hypothyroidism? Because of the pleural cavity effusion. Why in thyroid oxidosis? Because of the increase in the circulating carbon dioxide due to increased breakdown of the glucose. Clear? Fourth point is the blood pressure. You already know what will be the changes in the blood pressure. In hypothyroidism, you will get isolated diastolic hypertension, and in thyroid oxidosis, you will get wide pulse pressure in the form of sharp elevation of the systolic BP and drop in the diastolic BP, so that the pulse pressure is augmented. The last one is the neck veins and the neck glands that we will discuss regarding the clinical evaluation of the patient. So let's have a quick recapitulation. Just turn on your microphone and tell me the clinical findings of general survey, which you will look for the assessment of a thyroid swelling. Start from the higher function. Anyone, just turn on your microphone and tell me the classical findings of general survey.
Sir, should we speak about specific conditions or in general like the bulbo?
Just have a prompt recapitulation. Just tell me.
Sir, if we are starting from the
First higher function. Higher function.
Sir, first and whether the patient is well oriented to time, place, and person, and if we find that the patient is not well oriented or
drowsy, lethargic, hypothyroid, restless, irritated, thyroid oxide, higher function. Then base nutrition, thyroid swelling, dwarfism, congenital hypothyroidism, or cretinism.
Yes.
Next is nutrition. Body mass index low, likely thyroid oxidosis. Body mass index likely hypothyroid. Anemia.
Mild to moderate anemia due to iron deficiency.
Why iron deficiency?
Iron also due to lack of formation of transferrin, which is required for transport of iron.
Yeah. So patient will have clinical features mimicking iron deficient anemia, but it doesn't respond to the iron replacement.
Yes.
Finished. Cyanosis, no direct relationship. Jaundice,
discoloration of sclera due to retinal deposition.
But no relationship with the bilirubin metabolism, so the LFT is absolutely normal. Next is pulse. Tell me classical findings of pulse.
So in hypothyroidism,
both the pitting edema as also the non-pitting edema.
In hypothyroidism, it is due to loss of osmolarity and non-pitting due to mixed edema. And in pulse, in hypothyroidism, we will have sinus bradycardia. In hyperthyroidism, we will have either sinus tachycardia, which is divided into 4 stages. Stage 1, sinus tachycardia, then atrial fibrillation, then atrial flutter, and then ectopic beats. And second is patient can have water member pulse due to wide pulse pressure, with increasing systolic blood pressure and decreasing diastolic blood pressure. And third will be, in case of hypothyroidism only, there will be increasing arterial stenosis due to atherosclerosis, which is due to deposition of cholesterol and leading to thickening of arteries. And then it will temperature. Hypothyroid, in case of hypothyroidism, the body temperature will be higher, which is due to peripheral vasodilation and increased sweating in the palmar surface. And hypothyroidism will have isolated diastolic hypertension due to intense peripheral vasoconstriction. And along with
cold extremity, another dry extremity.
Cold extremities. And in case of respiration, then both hyper and hypothyroidism will have increased respiratory distress. In hypothyroidism, tachypnea is due to pleural effusion. And in hyperthyroidism, respiratory distress is more due to glucose oxidation leading to increased carbon dioxide production and simultaneously increased stimulation to the respiratory center and increased tachypnea.
Okay. Yeah, that's very good. Now just wait for 1 minute. We are focusing our discussion towards the patient. No, দেখে একবার ঠোক গেলুম তো দেখি সোজা হ্যাঁ ঠোক গেলুম দেখি আবার I request everyone to go for the assessment of this swelling and have an idea regarding the clinical evaluation. I'm asking the patient to swallow and just look for the assessment of the thyroid swelling. ঠোক গেলুম তো একবার ভালো করে Now, anyone just tell me what are your inspectory findings for assessment of the thyroid swelling as for the other swelling. You have to go for the inspection, palpation, percussion, and the auscultation. So let's start with the point of the inspection. Anyone just tell me what are your inspectory findings. You have to narrate your inspectory findings. You have to document something and you have to rule out something. Just on the basis of this evaluation, just tell me what are your inspectory findings. Anybody, just tell me your inspectory findings, which you can visualize just on the basis of this laptop. Just tell me what are the findings.
So there is a swelling in the anterior neck in the midline, which moves which moves vertically with deglutition. So it is likely a thyroid swelling.
Anything more? You want to elaborate something more? Okay. A globular swelling about 4 by 5 centimeter in maximum dimension, located in the front of the neck, with all the margins well demarcated, including the lower margin, which is well above the suprasternal notch. So what we get? A globular swelling about 5 by 6 centimeter in maximum dimension is present in the front and right side of the neck. All the margins of the swelling are well demarcated, including the lower margin, which is about 2 centimeter above the suprasternal notch. The swelling itself is moving up and down with deglutition. But there is no concomitant movement of the swelling with protrusion of the tongue. The skin over the swelling is healthy. There is neither arterial pulsation nor any venous prominence. There is no prominence of the facial veins or the neck veins. There is no other associated swelling in any other part of the neck. That is, we are ruling out any concomitant lymph node enlargement. So what are your findings on inspection? There is a globular swelling about 5 by 6 centimeter in maximum dimension, present in front of the neck and also extending up to the right side of the neck. All the margins are well demarcated, including the lower margin, which is about 2 centimeter above the suprasternal notch. Skin over the swelling is healthy. There is neither arterial pulsation nor any venous prominence. There is no prominence of the veins in any part of the face or the neck. On the right side, the swelling is extending up to the anterior margin of the right sternocleidomastoid. On the medially, the swelling is extending up to the midline. Below, the swelling is extending up to a point about 2 centimeter above the suprasternal notch, and above the swelling is extending up to the level of the thyroid cartilage. There is no other swelling in any other part of the neck. Finished? So just tell me why a thyroid swelling moves up and down in deglutition. Anyone? I think all of you know that, but just a recapitulation. Why a thyroid swelling move up and down with degradation?
So because it is enclosed in the pretracheal fascia, which is derived from the deep layer of the derived from the investing layer of the deep cervical fascia. So and it is attached anteriorly to the thyroid cartilage. Yes, so to the thyroid cartilage by the ligament of Berry. So because of that, when you go on deglutition, it moves up and.
Okay, that's very good. Now the second question will be, name the conditions in which you get a thyroid swelling, but the swelling don't move up and down in degradation. So the next question will be, there is a thyroid swelling, but under which circumstances the thyroid swelling will not move up and down in degradation?
When it is fixed to the underlying structure, when in advanced.
Which underlying structure? There are 2 or 3 clues. One is huge goiter with extensive surrounding tissue infiltration. Second, anaplastic variant of the thyroid carcinoma, which is usually arranged in all the surrounding structures. Third is huge retrosternal goiter with retrosternal tissue space extension and fixation. And finally, reduced thyroiditis, which is an autoimmune disorder. Because of the extensive inflammation, the tissue gets deposited and gets fibrous so that the thyroid gland cannot move up and down. So these are the conditions in which, in spite of a thyroid swelling, the swelling don't move up and down in degradation. First, a huge goiter with extensive tissue infiltration. Second, anaplastic variant of the thyroid carcinoma with extensive surrounding tissue infiltration. Third, huge goiter with retrosternal extension and fixation. And fourth, reduced variant of the thyroiditis because of the extensive inflammatory changes. Though it's a thyroid swelling, they don't move up and down in degradation. Clear? Next question is, other than thyroid swelling, tell me the conditions in which you can get a swelling in front of the neck, which also move up and down in degradation. The next question is, other than the thyroid swelling, name some conditions in which you will get some swelling in front of the neck, which also move up and down in degradation.
Thyroglossal cyst.
Very good. Next one.
Sir, bursitis.
Any parathyroid neoplasm, sir?
Parathyroid neoplasm very much unusual for movement with the degradation because it has got no attachment with the ligament of Berry. So first one is thyroglossal cyst, and you have to delineate it from the thyroid swelling by simple transprotrusion test. Second one, subhyoid bursitis. Third, any laryngeal swelling or tracheal swelling. Because of the investment of the ligament of the Berry, all of the swellings may also move up and down with the degradation. So what are the swellings which may also move up and down with degradation? Any thyroid swelling. Second, thyroglossal cyst. Third, subhyoid bursitis. And fourth, any laryngeal or tracheal swelling which has got an attachment with the ligament of Berry. Clear? So these are your clues which I have to tell during your period of inspection. Now move on to the palpation. So tell me, what are the classical ways of palpation of a thyroid swelling and which method should be employed under which circumstances? What are the classical methods of palpation of the thyroid gland? There are 3 methods. Just tell me the names.
Lurie's method, Kral's method, sir.
Very good. Okay. Now regarding the palpation of the intra-abdominal organs, what will be your instruction towards the patient? You have to ask the patient for the flexion of the hip joint and the knee joint so that the anterior abdominal muscles are relaxed. Only then you can palpate the underlying viscera. Similarly, for the palpation of the thyroid swelling, you have to make the anterior strap muscles relaxed. And so as to maintain the same, you have to flex the neck. So how much the neck should be flexed? 15 to maximum 30 degrees, because beyond that, the neck will be obliterated. So for the palpation of a thyroid swelling, the classical method is the Lehis method. For that, you have to make the anterior neck muscles relaxed. To do the same, you have to flex the neck by the extension of the 15 to 30 degree, so that the neck muscles is relaxed and you can palpate the thyroid swelling in a better way.
যেটা আমি বলে বলে দিচ্ছি, তাহলে বলা হবে না। দেখি দেখি চলে 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 আমি তো সব বলে দিচ্ছি। ফার্স্ট ইজ লেগিস So first is Leahy's method. First step, flex the neck to the extent of the 15 to 20 degree. Maintain this posture by placing both of your thumbs over the nape of the neck. So first step is flexion of the neck, how much? 15 to 20 degree, so that the anterior neck muscles is relaxed. Place both of your thumbs over the nape of the neck so as to maintain this posture. Then place your other fingers in front of the neck. For the palpation of the right lobe, push the left lobe more towards the right side so that the right lobe becomes more prominent. Now, the help of the palmar surface of the remaining part of the right four fingers, you have to palpate the thyroid swelling. So what are the clinical steps? First is flexion, how much? 15 to 20 degree. Second, placing both the thumbs over the nape of the neck so as to maintain this posture. Third, push the left lobe of the thyroid gland towards the right side so that the right lobe becomes more prominent. Now, with the help of the palmar surface of the right four fingers, you have to palpate the thyroid swelling. Now, tell me, what will you tell when the teacher is asking you what are your palpatory findings? What will be your answer? Your ideal answer will be, all of my inspectory findings have been confirmed by palpation. So there is no necessity to describe the same features again during palpation. Plain and simple, all of my inspectory findings have been confirmed by palpation. In addition to that, temperature, tenderness, mobility, assessment of nodularity, fixation with the underlying structures, and assessment of the neck nodes. But what will you say on palpation? All of my inspectory findings have been confirmed by palpation. In addition to that, you have to tell about temperature, tenderness, assessment of nodularity, mobility or movement of the swelling, along with assessment of the underlying structure compression and assessment of the lymph node. Keep it in mind, until and unless you palpate the neck nodes, your neck examination is not finished at all. So be careful, your palpation should include palpation of the neck nodes. So just tell me what could be your palpatory findings. First, temperature. If you get, what are the possibilities? Body temperature normal, so also the temperature overlying the goiter. So the patient is euthyroid. Second possibility, body temperature raised, so also the temperature of the thyroid gland. It indicates thyroid oxycosis. And third one, body temperature is normal, but the local temperature is raised. It indicates reduced thyroiditis or an autoimmune inflammatory changes. So first, regarding temperature, there could be three isolated findings. Body temperature normal, so also the temperature overlying the gland. Patient is euthyroid. Second possibility, body temperature elevated, so also the temperature overlying the gland. Likely thyroid oxycosis. Third possibility, body temperature is normal, but the local temperature is raised, likely because of the reduced thyroiditis. So temperature is finished. Next one is tenderness. If the swelling is tender, what is the take-home message?
It could be an inflammatory swelling.
One possibility is inflammatory swelling, likely reduced thyroiditis. Second one is intrathyroid sudden hemorrhage, which could be a manifestation of the underlying malignancy. So initially it was a painless, non-tender swelling, but because of the intraglandular hemorrhage, it could be a tender one. So if you get a tender swelling in the background of the thyroid swelling, the possibilities are, first is inflammatory autoimmune thyroiditis or reduced thyroiditis. Second, intracystic or intracolloidal hemorrhage could be a manifestation of the underlying malignancy. So temperature is finished, tenderness is also finished. Next one is assessment of nodularity. This is a very important clue regarding your final diagnosis. If you get more than one nodule, you call it as a case of the multinodular goiter. So your assessment, there could be without any nodularity or presence of nodularity.
In most of the cases, if you get a multiple nodule, even if more than one, you stamp it as a case of the multinodular goiter. Next is fixation with the underlying structures. So what are the underlying structures you are looking for? One is the trachea, one is esophagus, one is the recurrent laryngeal nerve. Fortunately, we don't have any bedside clinical test for evaluation of the esophagus and the recurrent laryngeal nerve. So only one test, that is the assessment of the trachea by the Cock's test. So how to do the Cock's test? First is extension of the neck so that the trachea becomes more prominent. How much extension? Again, 15 to 20 degrees. First, you have to identify the trachea. There could be tracheal displacement because of the extensive thyroid swelling. So what are the two fixed landmarks? One is the Adam's apple, one is the suprasternal notch. So trachea ideally should lie along this line. So what are the landmarks? The Adam's apple and the suprasternal notch. The line joining the two indicates the trachea. So these are the tracheal rings. The first, second, and the third and fourth tracheal rings. Ideally, you should not palpate the trachea over the first and second tracheal rings, as these are the incomplete rings, so there is a chance for the tracheal injury. So place your thumb just 2 centimeters above the suprasternal notch over the third or fourth tracheal rings. Press it just for 5 seconds. Look for the stridor. If the stridor is present, patient is likely to have a tracheal involvement or tracheobalacia. It doesn't signify malignancy, but it signifies there could be a huge swelling which is causing compression over the trachea. So Cock's test, how to elicit the same? First, extension of the neck, 15 to 20 degrees. Identify the landmark, the Adam's apple, the suprasternal notch. Join the two lines. Place your thumb just 2 to 3 centimeters above the suprasternal notch. Make a firm compression over the trachea just for 5 to 10 seconds. Look for the stridor. If stridor is present, there is tracheal involvement or tracheobalacia, but it never signifies it's a malignancy. It signifies there is a huge swelling with tracheal involvement or with tracheobalacia, but it doesn't signify the malignancy. Next.
Sir, one query, sir. How will the patient demonstrate stridor? I mean, how will we see it? What will be the finding in this case? How will
sudden respiratory distress? There will be sudden respiratory distress along with a choking effect. If you compress the trachea, if there is any tracheal involvement, there will be choking effect and sudden respiratory distress. Yeah.
Okay, sir. Okay.
From lateral to medial.
Next one is the assessment of the carotid artery or the Berry's side. So how to assess the carotid artery? First, you examine the clinically apparently normal looking side. That is the left one. The left one at first. The apparently normal looking side at first. Turn the face towards the contralateral side against resistance. Turn the face to the contralateral side against resistance so that the sternomastoid becomes prominent. Divide the sternomastoid in upper third, middle third, lower third. So at the junction of the upper third and the middle third, on the medial side, you will get the carotid artery pulsation. So turn the face to the contralateral side against resistance so that the sternomastoid becomes more prominent. Place your thumb just medial to the upper 1/3 of the anterior sternomastoid so that you get the carotid artery pulsation. Then assess and compare it with the other side. Now tell me, when you say the Berry sign is positive, when there is significant diminution in the intensity of the pulse or total absence of the pulse as compared to the other side, we call the Berry sign is positive. So there should be significant drop in the intensity of the pulse as compared to the other one, or total loss of the pulse, then we call the Berry sign is positive. It's a feature of the malignancy because of the direct infiltration of the malignant tissue into the carotid sheath. So again, I repeat, Cock's test never signify it's a malignancy, but positive Berry sign always signify it's a case of the malignancy. Next question. Just tell me, will you go for the assessment of both the carotid artery at the same time? Anyone just tell me whether you will jump for assessment of both the carotid artery at the same time or one at a time?
We'll do both at the. No, we'll have to do one at a time because we are flexing the neck to other side, so we have to evaluate one at a time.
So we can simply place both your fingers like this, and you can have an assessment regarding the carotid artery pulsation. You can feel both your index finger or the thumb finger at the same time.
No, we will not do the same at the one time. Because there will be bilateral compensation of the vagus nerve, it will be suddenly heart block.
Very good.
This will bilateral.
Because this, yeah, you are absolutely right. In this region, just tell me. Okay, here there is the carotid bulb, which is supplied by the vagus nerve. So if you suddenly compress both the vagus nerve at the same time, there is a chance for the cardiac arrest. So always you palpate one carotid artery at a time, then you compare it to the other time, not both the two carotid artery at the same time. Clear? So our first method was the Lehis method from the back. The same method can be applied from the front also, but preferably we do it from the back side. Now, first step of the Lehis method was flexion. Now, if the patient is having a short neck, and if you flex even for 15 degree, there will be obliteration of the neck. So, second method for a patient who are having a short neck is the Pizulos method. So, Pizulos method is classically employed for a patient having a short neck. So, what will be the maneuver? Now, the patient will extend her neck to the extent of 15 to 20 degree, and patient will maintain the posture by himself or herself by placing both the hands by the side of the neck. So first step is extension of the neck to the extent of the 15 to 20 degree. Patient will maintain this posture by placing both the hands on the back. Now ask the patient to go for the proper visualization. And the remaining part is the same. You stand in front of the neck, you place your thumb in such a way so that you are pressing the left lobe so that the right lobe becomes more prominent. Now you will palpate the left lobe, and the vice versa for the same time. So first method is the Lehis method for a apparently normal looking patient. When the patient is having a short neck, you switch over to the Pizulos method. When the patient will extend the neck to the extent of 15 to 20 degree and maintain this posture. Remaining part is the same and the assessment is the same. Hello. না ছেড়ে দাও জানিয়ে দাও যেতে পারছো না আমি ক্লাস নিচ্ছি পরে কথা বলছি যেতে হবে The third one is the Kreil's method. When you will go for the Kreil's method? Selectively for a very small thyroid swelling or for the solitary thyroid nodule. So first was is Lehis method. For a solitary thyroid nodule, if you flex it, it will get disappear. If you extend the neck, because of the contraction of the strap muscles, you won't be able to visualize it. So for solitary thyroid nodule having a small swelling, keep the neck in the anatomical position. Ask the patient to swallow. The swelling will move up and down. With the help of your thumb only, you have to palpate the swelling from the front. So Lehis method for a normal looking person can be done from front, can be done from the behind. Next one is the Pizulos method for a patient having a very short neck. Third one is the Kreil's method for a patient having a small solitary thyroid nodule in which the patient will maintain the normal anatomical position. Ask the patient to swallow. The swelling will move up and down. At the time of the movement, you have to palpate the swelling with the help of your thumb and you have to describe the palpatory findings. The next part of the palpation, there are two left only. First, whether finger can be inseminated between the lower margin of the thyroid swelling and the suprasternal notch, which directly proves that there is no retrosternal extension. And finally, assessment of the neck nose. So what will be the sequence for assessment of the palpation? First, Lehis method, assessment of the temperature, tenderness, mobility, compression or even evidence of compression of the underlying structure. Only two structures, one is the trachea, one is the carotid artery. Next, palpation of the lymph nodes. Then, whether finger can be inseminated between the lower margin of the thyroid gland and the suprasternal notch. So, anyone just tell me what will be your clinical findings? Just tell me, suppose it's a you get a multiple nodules and the patient local temperature is normal. So what will be your clinical findings on palpation? You just tell me. Anybody just have a recapitulation? It's for your benefit only. Just tell me what are your findings on palpation? Just a way of talking where you are thinking about. Nothing more than that. Just tell me your findings. Anybody please? Just give me some points only.
Sir, first of all, we evaluate by palpation by Ly's method. In there, we'll see the temperature first, whether it is raised or normal or decreased.
First, you have to tell all of my inspectory findings have been confirmed by palpation. So no
Yes,
logic
sir,
for description of the same swelling, side size, shape, surface margin. All have been finished. Along with that, temperature, tenderness, assessment of nodularity, assessment of mobility, assessment of fixation with the underlying structures, whether the finger can be insulated between the lower margin of the thyroid gland and the suprasternal notch, and finally the neck nodes. Now just tell me.
So all my inspirative findings are confirmed by palpation. On other findings, the temperature is normal. The patient does not have any tenderness over the swelling. There are on palpation, multiple nodules are palpable, and the swelling can be easily moved without any restriction. So there is no attachment of the swelling to the underlying structures. On examination of the carotid pulse, will we tell about the carotid pulsation here?
Just tell the carotid pulsation is intensity is equal on both the sides, or the very sign is negative.
The carotid pulsation is equal on both sides, and the swelling does not show. Apart from that, the last point would be whether we can insinuate our finger between the suprasternal notch and
lower margin of the thyroid gland and the suprasternal notch.
Could we tell about the consistency also in here? If the swelling is hard or
yeah, obviously. Absolutely. I forget to mention the same.
So
obviously, you have to tell the consistency. I really forget about that.
Yes. So obviously, I have to tell about the temperature, the tenderness, nodularity, movement of the swelling, and presence of any whether carotid pulsations are equal, whether attached to underlying structures, consistency, and whether lower border of thyroid is palpable or not. Confirm whether retrosternal thyroid is present or not.
Very good. So palpatory findings is finished. So the final step will be assessment of the neck nodes. You know the level of the neck nodes, and I think all of you know how to assess the neck nodes. Now move on to the percussion. So for any thyroid swelling, you have to rule out if there is any retrosternal extension. Now, which structure resides on the posterior surface of the manubrium sterni? This one is the manubrium sterni. Here is the lower margin of the thyroid swelling. So there could be a finding the swelling is extending beyond the manubrium sterni. For a normal person, which structure lies just posterior to the manubrium sterni? The apex of the pleura, which contains the air. So if you directly percuss, there is simple direct percussion without like this. So direct percussion, it will be resonant in nature because of the air trapped within the apex of the pleura. But if there is retrosternal extension of the goiter, which is solid in nature, if you directly percuss over the manubrium sterni, it will be dull in nature. So in presence of the retrosternal extension of the goiter, if you percuss over the manubrium sterni by direct percussion, it will be dull in nature. Otherwise, it will be resonant in nature. So next question will be how to assess the retrosternal extension of the goiter. So the straightforward question is how to assess or how to look for the retrosternal extension of the goiter. So we have to make it confirm by the way of the Pemberton test. So how to demonstrate the Pemberton test? Ask the patient to elevate both the hands so that it touches the ears. Ask the patient to elevate both the hands and the hands will touch the ears. You ask the patient to maintain this posture for 2 minutes. Look for the facial condition, look for the prominence of the facial vein and the neck veins. If the facial veins becomes prominent, also the neck veins, or if there is an evidence of the facial condition, the Pemberton sign is positive. So this will be the posture. You have to maintain this posture for 2 minutes. You have to look for the prominence of the facial veins or neck veins and the facial condition. If any of the finding is present, we call the Pemberton test is positive, and the clue is that there is retrosternal extension of the goiter. Now tell me why there will be positive Pemberton test if there is any retrosternal extension of the goiter. You have to know the explanation, then we can only face the crossing in your final examination. Tell me why there will be positive Pemberton sign or prominence of the facial vein or the neck veins when there is a retrosternal extension of the goiter. What's the reason? Okay, just have a discussion. Anyone just tell me what is the venous drainage of the upper extremity? Anybody, just tell me the basic veins which are involved in the venous drainage from the upper extremity.
Sir, in the arm we have the cephalic vein and the
And the axillary
which drains into the
axillary vein.
axillary vein, which goes then drains into the subclavian on the.
Okay, the cephalic vein and the axillary vein. Ultimately, both of the veins drain into the subclavian vein.
Yes.
Now, subclavian vein joins with which vein? This vein. The subclavian vein joins with which vein? Which courses posterior into the sternum. No, not at all. Brachiocephalic lies in the chest cavity, not in the neck.
Internal jugular vein.
Internal jugular vein. So first drainage is axillary and subclavian vein joins with the internal jugular vein to form the brachiocephalic vein. The right and left brachiocephalic veins join with each other just posterior to the manubrium sterni and then turn on the right side to form the superior vena cava. So the venous drainage is that leads into the subclavian vein. Subclavian vein joins with the internal jugular vein to form the brachiocephalic vein. Right and left brachiocephalic vein joins with each other just posterior to the manubrium sterni and then turns on the right side to form the superior vena cava. Now, if you ask the patient to elevate the upper extremity, what will happen to the venous return? Will it be increased or decreased or static?
It will be decreased due to compression of. No, it will be.
So venous return to the heart will be decreased due to compression of the.
More specific. Compression occurs at the level of the superior vena cava, not at the level of the upper.
SBC obstruction. Yes, sir.
That's a late sequelae. If you elevate both of your arms, what will happen to the venous return? By the action of the gravity, what will happen to the venous return?
It will increase. It will increase.
So more amount of blood will percolate through the axillary vein, then through the subclavian vein, and more amount of blood is getting into the right and left brachiocephalic vein. Now, venous wall is distensible, so it will need some amount of space for the distension. So ultimately, the brachiocephalic vein of the right and left side will get distended so that to accommodate this extra amount of blood. But what will happen if there is retrosternal goiter, which is a solid structure, it will cause compression over the right and left brachiocephalic vein. So if there is any compression over the right and left brachiocephalic vein, will the vein be able to get the proper distension so as to accommodate this extra amount of blood?
No.
So then what will happen? Blood will migrate into the reverse direction. Blood will return back into the reverse direction. So blood will finally go into the reverse direction where from it was coming, that is into the subclavian vein or into the internal jugular vein.
Internal jugular vein.
So now either into the internal jugular vein or will go back into the subclavian vein. Now, in presence of a condition in which the upper extremity is raised, where the blood will go, the clue is both in the subclavian vein as also in the internal jugular vein. Second option is only subclavian. Third option, only internal jugular vein, where the blood will go. Your clue is that patient is elevating her extremity and now the blood has to get pumped against the gravity. Which vein is now against the gravity? The subclavian vein or the internal jugular vein? Anybody just tell me? The logic is quite clear. There is retrosternal extension of the goiter which is solid in nature. Extra amount of blood is coming out through the upper extremity as we are elevating the arms. So there needs some amount of distension of the brachiocephalic vein to accommodate this extra amount of blood. Now retrosternal goiter is compressing over the brachiocephalic vein. This extra amount of blood cannot be pumped into the superior vena cava, so there will be regurgitation of the blood into the opposite direction where from it was coming. So blood may go either into the both the circulation, that is subclavian and internal jugular, or selectively into the subclavian or selectively into the internal jugular vein, in which vein the extra amount of blood will come back. It will obviously come into the internal jugular vein because the subclavian vein is under the effect of the gravity. The subclavian vein is under the effect of the gravity and the venous pressure is not good enough to overcome the effect of the gravity. So as the upper extremity is elevated, so subclavian vein is under the pressure of the gravity. So the venous blood which has got a lower pressure cannot overcome the effect of the gravity. But the internal jugular vein is not at the effect of the gravity, so the blood will now migrate into the internal jugular vein only. So this extra amount of blood will go back into the internal jugular vein. So what will happen to the drainage area of the internal jugular vein, which lies into the face? So there will be facial condition. It also drains from the neck, so there will be prominence of the neck veins. So we get the idea why the Pemberton test is positive in presence of retrosternal extension of the goiter. As we elevate the upper extremity, there will be augmentation of the venous return. More amount of blood is ultimately draining into the brachiocephalic vein, which needs distension to accommodate this extra amount of blood. In presence of the retrosternal goiter, which will cause over compression over the brachiocephalic vein, leading to non-passage of the blood from the brachiocephalic vein into the superior vena cava. Rather, there will be regurgitation of the blood. As the subclavian vein is under the effect of the gravity, blood will selectively go into the internal jugular vein. So the drainage area of the internal jugular vein will become more prominent. So what are the drainage area? The facial region and the neck region. So there will be facial condition along with condition of the neck veins. So there lies the importance of the assessment of the Pemberton sign. So if you are being asked in the examination how to assess the retrosternal extension of the goiter, your answer should start from the history. From history, there is no evidence of the facial condition or prominence of the neck veins. On inspection, the lower margin of the thyroid swelling is well delineated and it is about 2 cm or 3 cm above the suprasternal notch. On asking the patient to swallow, I can see the lower margin in a better way and this is well above the suprasternal notch. On palpation, I can put my finger or I can instrument my finger between the lower margin of the thyroid swelling and the suprasternal notch. Third, on direct percussion, it is not dull in nature. And finally, confirmed by Pemberton sign. So regarding assessment of the retrosternal extension, always start from the history, never jump directly into the Pemberton sign. We have to face the history, the inspectory findings, your palpatory findings, your percussion findings, and finally the Pemberton sign. Clear? Okay, up to this point, any confusion or any query?
Sir, is Pemberton sign positive for any, even the smallest thyroid swelling that has become retrosternal, or is it only positive for very large swellings?
Okay, nowadays the WHO has classified the retrosternal goiter into 3 categories. The category 1, that is the extension of the goiter above the aortic arch. Category 2, aortic arch 2, above the right atrium. and category 3 extending behind the right atrium. Usually the important sign is positive for category 2 and category 3, usually not found in category 1. So more the amount of thyroid tissue into the retrosternal space, more is the chance for the compression, more is the chance for the positivity of the retrosternal goiter. So if you give the better answer, your answer will be it is more prominent in case of category 2 and category 3, WHO retrosternal goiter, category 1 up to the aortic arch, category 2 from the aortic arch up to the right atrium, and category 3 behind the right atrium. Obviously, it will be positive for category 2 and category 3, may or may not be positive in category 1. So totally depends on how much the thyroid tissue is extending into the retrosternal area. Clear?
Okay, sir. Thank you.
Okay. Then we'll go for the assessment of the toxicity. So first you tell me, what do you mean by primary toxicosis and what do you mean by secondary toxicosis? Usual nomenclature is not applicable for thyroid swelling toxicity because all of you know that primary means the pathology resides within the organ itself, and secondary means the pathology is other than the primary site, but there is some degree of alteration of the primary tissue, so there is toxicosis. This definition is not applicable in case of thyrotoxicosis. So anyone just tell me if you know what you mean by primary toxicosis and what you mean by secondary toxicosis. Anyone, please? Okay. Just have an idea. When the appearance of the goiter is synchronous with the appearance of the toxicity, that is, both are appearing at the same time, we call it the primary toxicosis. Again, when the appearance of the goiter is synchronous with the appearance of the toxicity, that is, both are appearing at the same time, we call the primary toxicosis. In primary toxicosis, the gland is usually non-nodular or smooth, uniformly enlarged, and cardiovascular signs are more prominent. So what we get? Primary toxicosis means when the appearance of the goiter is synchronous with the appearance of the toxicity. That is, both are appearing at the same time, we call the primary toxicosis. Then what do we mean by secondary toxicosis? Initially there is a goiter, but no sign or symptoms of the toxicosis up to a definite period of time. After that, there is progressive appearance of the toxicity. We call the secondary toxicosis. So what is primary toxicosis? When the goiter and the toxicosis are appearing at the same time, we call the primary toxicosis. When initially goiter is present without any clinical evidence of the toxicosis, later signs and symptoms of toxicosis are appearing, we call the secondary toxicosis. Clear? Now we have to go for the assessment of the cardiovascular toxicity, followed by assessment of the neurological toxicity. So start with the cardiovascular one. First one is assessment of the hyperdynamic circulation. As you know, in case of thyrotoxicosis, heart is pumping in a more aggravated fashion and heart is pumping against a wide pulse pressure. Now all of you know that. Because of the positive inotropic and chronotropic effect, heart is ejecting the blood more forcefully, and that too against a wide pulse pressure because of the concomitant lowering of the pulse diastolic BP. So what will happen to the velocity of the blood flow? Anybody just tell me, if your heart is contracting more forcefully, that too a wide pulse pressure that is against a lowering of the diastolic blood pressure, then what will happen to the velocity of the circulating blood volume? What will happen to the blood velocity?
It will increase blood velocity.
So there will be, the velocity will be increased. So we have to assess the hyperdynamic circulation by simply pressing over the nail beds. Battery running low charger. So first assessment of the cardiovascular system is number one, assessment of the hyperdynamic circulation. I am not sure whether you can watch it properly. This is your nail bed. Press it firmly. Your nail bed will be white in color. It will be blanched. You release it. There will be capillary refilling. Same thing for the pulse space also. You press it firmly, there will be avascularity. You release it, there will be capillary refilling. This capillary refilling time is roughly for 2 seconds, which will be curtailed in thyrotoxicosis. So assessment of the cardiovascular system, first is assessment of the hyperdynamic circulation. That is, you are directing that the blood is moving in a more forceful and more automatic fashion so that the velocity is increased. How to assess the same? Assessment of the capillary refilling by pressing over the nail or by pressing over the pulse space, in which the capillary refilling time, which is normally around 2 seconds, will be curtailed around 1 second or even less than that. So first is capillary refilling. Second, palpation over the palmar surface. What will be your impression? Warm and moist in case of thyrotoxicosis, cold and dry in case of hypothyroidism. So the first finding was assessment of capillary refilling. Second, palpation over the palmar surface of the hand and comment if it is warm and moist in case of thyrotoxicosis and cold and dry in case of hypothyroidism. Third is palpation over the radial artery, and you have to narrate all the points in favor of your diagnosis. Now, all of you know what are the palpatory findings on radial artery. Next is assessment of the blood pressure and document white pulse pressure. And finally, you move over the precordium. Then what is the sequence? Number 1, capillary refilling. Number 2, palpation over the palm, warm and moist or cool and dry. Third, radial artery. Again, tell all the classical features of the pulse. Fourth, brachial artery. Comment about the white pulse pressure. And finally, you move over the precordium. Now, in the precordium, first you have to palpate the apex beat. From your remote memory of the physiology, just tell me what do you mean by the apex beat. Anybody, just tell me. None of you are cardiologists, just simply give me a definition regarding the apex beat. What do you mean by the apex beat? And where the normal apex beat is located?
So apex beat is the leftmost impulse of the heartbeat that is felt on palpation of the chest, and it is usually located just in the left fourth or fifth intercostal space, lateral to the mid axillary line.
Mid?
Sorry, not axillary, clavicular line. Yes,
okay. Okay, that's fine. So it is the most prominent, outermost and downmost thrust given by the left ventricular apex, which is usually located in the mid-clavicular line, just 2 centimeters away from the mid-clavicular line, usually in the left fifth intercostal space. So it is basically the force given by the left ventricular apex. Now just have the scenario. Patient is having a thyrotoxicosis. So what will happen to the force of contraction of the left ventricular apex? Normal, decreased or increased? What will happen?
It will increase.
So it will be forceful. Agreed? So because of the chronotrophic effect, there will be forceful contraction of the heart, also the forceful contraction of the left ventricular apex. So the apex beat will be forceful. Second, duration. In thyrotoxicosis, there will be at least sinus tachycardia. So what will be the duration of a single cardiac cycle? Normal, increased or decreased? Anybody just tell me?
Decrease.
In presence of thyrotoxicosis, decreased. So what will happen to the duration? Very good. So what will happen to the duration of a single cardiac cycle? Decreased. So what will happen to the duration of the apex beat? Decreased. That is known as the ill-sustained. So the nature of the apex beat will be forceful but ill-sustained. Why forceful? Because of the positive chronotrophic effect. Heart is contracting more vigorously. So also the left ventricular apex. Why ill-sustained? Because of the tachycardia, the duration of a single cardiac cycle is reduced. So also the duration of a contraction of the left ventricular apex. So now the LV apex will be, or the apex beat will be forceful but ill-sustained. Second point. Third point. what will happen to the cardiac musculature if the heart has to pump more vigorously, contracting more efficiently? What will happen to the cardiac musculature, the length and the breadth? There must be hypertrophy in both the directions because heart has to pump in a more vigorous way. So there must be hypertrophy of the. So in both the direction, the longitudinally as also in the transverse direction. So what will be the change in the apex speed as the cardiovasculature are growing more efficiently in both the directions, that is downwards and outwards? As there will be increase in the longitudinal diameter, so the apex speed will be shifted downwards, and at the same time there will be more transverse lengthening of the cardiac musculature, so the apex speed will finally be shifted downwards and outwards. So finally your result will be apex speed is forceful, ill-sustained, deviated downwards and outwards. That is a hallmark of the thyroid oxycosis. So what will be your first finding on precordium on assessment of the apex speed in presence of thyroid oxycosis? The apex speed will be forceful, ill-sustained, deviated downwards and outwards. Clear to all of you?
Yes, sir.
Okay. Now think about what happening within the heart itself. Now tell me what will happen to the circulatory blood volume in presence of thyroid oxycosis. What will happen to the circulatory blood volume? The status quo or increased or decreased?
Sir, could you repeat the question, please?
What will be the circulatory blood volume in presence of thyroid oxycosis? Remain the same or increased or decreased? What will be the circulatory blood volume?
Blood volume will remain the same, sir.
So there will be hyperdynamic circulation.
And what about the circulatory blood
volume will
volume?
remain the same, but the pressure will be raised.
Okay. Just to give you the clue, thyroid hormone in presence of severe toxicosis, there is some degree of stimulation of the erythropoiesis. So RBC mass will be increased, so also some amount about the plasma volume also in presence of severe toxicosis. So in presence of severe toxicosis, there will be some degree of stimulation of the erythropoiesis. So RBC mass will be increased, so also the plasma volume, so that ultimately the circulatory blood volume is raised. So now the heart will have to accommodate this extra amount of blood. Now, what is the course of circulation within the heart? The right atrium getting the blood, then going to the right ventricle, from the right ventricle going to the pulmonary circulation, then coming back into the left atrium. So if more amount of blood is coming into the left atrium, what will be the volume of the left atrium? Left atrium now has to accommodate some extra amount of blood. So what will be the dimension of the left atrium? Am I audible? Yes. Question was that in presence of severe toxicosis, some amount of erythropoiesis is stimulated by the thyroid hormone. So RBC mass is increased, so also the plasma volume, so that the circulatory blood volume is increased. So left atrium has to accommodate this extra amount of blood. So if the left atrium has to accommodate extra amount of blood, what will happen to the diameter of the left atrium?
Diameter will also increase then.
Diameter will increase.
Also increase. So on echocardiography, we will get a large diameter of the left atrium, usually more than 4 centimeter. Now this extra amount of blood is coming from the left atrium into the left ventricle through the mitral valve. So now the extra amount of blood is coming from the left atrium through the mitral valve into the left ventricle. So mitral valve is a fixed structure. It cannot expand itself. So this extra amount of blood is now coming through the normal looking orifice of the mitral valve. So for now onwards, this mitral valve, which has got a fixed diameter, through which an extra amount of blood is coming out, so functionally it will behave as functional mitral stenosis. You got the point? Extra amount of blood is pumping from the left atrium into the left ventricle through a fixed diameter mitral valve. because the diameter of the mitral valve cannot be increased. So extra amount of blood is coming through the normal diameter mitral valve. As the mitral valve has to accumulate extra amount of blood, so it will behave as functional mitral stenosis. You got the point?
Yes, sir.
So what will happen to the auscultation in the precordium? You will get the classical murmur of mitral stenosis, that is the mid-diastolic rumbling murmur. So what are your palpatory findings? First is apex beat. Forceful, ill-sustained, deviated downwards and outwards. Second, on echocardiography, you get a left atrial diameter which is more than usually 4 centimeter. Third, on auscultation over the precordium, you can get a functional mitral stenotic murmur or mid-diastolic rumbling murmur. Now, this extra amount of blood ultimately reaching the left ventricle and then getting pumped into the systemic circulation through the aortic valve. So this extra amount of blood is now moving through the aortic valve, so it will behave like functional aortic stenosis. So what will be the murmur? A classical ejection systolic murmur. So we can get a mid-diastolic rumbling murmur because of the extra amount of blood passing through the normal appearing mitral valve, producing functional mitral stenosis. We are getting mid-diastolic rumbling murmur. Again, we can get an ejection systolic murmur because of the extra amount of blood passing through the normal appearing aortic valve, producing functional aortic stenosis. So finally, what are your findings on the precordium? Start from the apex beat. 4 points. Apex beat, forceful, ill-sustained, deviated downwards and outwards. Second, left atrial diameter. On echocardiography, more than 6 centimeter. Third, on auscultation, you can get mid-diastolic rumbling murmur because of the functional mitral stenosis and ejection systolic murmur because of the functional aortic stenosis. Any confusion or any discussion? Any confusion? So having very quick recapitulation. Cardiovascular feature, starting from the number 1, hyperdynamic circulation. At 2 points. One is nail bed, one is the pulse phase. Second, move over to the palmar space. Assess for warm and moist, cold and dry. Warm and moist, thyroidoxicosis. Cold and dry, hypothyroid. Go for the radial artery. Assessment of the pulse. Move on to the brachial artery. Assessment of the white pulse pressure. Move on to the precordium. 4 points. What are the points? Apex beat, downwards, outwards, deviated.
Deviated to the right side.
Left atrium diameter more than 4 centimeter. You can get mid-diastolic rumbling murmur. You can get ejection systolic murmur. So these are your classical cardiovascular findings which you can get in presence of the toxicosis. Finally, we have reached the neurovascular findings. That is the eye signs. Okay, just tell me the grading of the eye signs. All of you know that is NOSPCS. Anyone just tell me the nomenclature and the mnemonic. NOSPCS. N stands for no sign, no symptom. O stands for only sign, that is lid lag or lid retraction. A stands for soft tissue involvement. P, proptosis. E, extraocular muscle involvement. C, corneal involvement. And finally, loss of sight. So this is the grading of the eye signs in presence of a thyroidoxicosis. So before the detailed discussion, you just tell me what is the location of the eyeball. It is located within the bony eye socket. What are the boundaries of the eye socket? Above, lying by the superior orbital margin. Below, lying by the bony inferior orbital margin. Free anteriorly, and on the posterior side, there is the posterior bony socket. Between the eyeball and the posterior bony socket, there is the retroorbital pad of fat. In presence of thyroidoxicosis, this retroorbital pad of fat will undergo oxidation, producing glycosaminoglycan, which itself is a hygroscopic substance drawing water. So now there will be some amount of fluid accumulation within the eyeball itself. So what will happen to the eyeball? This extra amount of fluid will give some thrust or pressure over the eyeball. So eyeball has to accommodate itself by displacement in any direction. Is it possible for the eyeball to get displaced above as it is lying by the bony structure? Not possible. Not possible for displace into the lower structure, which is itself is a bony structure. So only one point is can get protruded anteriorly to accommodate the extra amount of fluid which is getting accumulated within the retroorbital space. So this is the basic pathology behind the proptosis or exophthalmos. What I have told, eyeball is found within the bony eye socket, lined above bony orbital fissure, below bony margin. Posteriorly, bony socket, and in between the two, there is the retroorbital pad of fat. The eyeball is free anteriorly. In presence of thyroid oxidosis, this retroorbital pad of fat will undergo oxidation, producing glycosaminoglycan, which is itself is a hygroscopic substance drawing water. So extra amount of fluid is now getting accumulated in the retroorbital space, pushing the eyeball. Now eyeball has to deviate itself. Only one side is possible, that is the anterior. So there is proptosis or forward bulging of the eyeball. Up to this, is clear for you. Now, what will happen if there is proptosis or forward bulging of the eyeball? That will give you the clue regarding the Nabjiga test and the other tests. So first one is the Nabjiga test for assessment of the eye size. So first look at that. If there is forward bulging of the eyeball, what will happen to the upper eyelid and the lower eyelid? The eyeball is moving forward or anterior. So what will happen to the upper eyelid and what will happen to the lower eyelid? If the eyeball is pushing anteriorly, so there will be upward displacement of the upper eyelid so that the eyeball can be accommodated anteriorly, and simultaneously there will be downward retraction of the lower eyelid. So up to this point, up to the normal state, the superior and the inferior orbital sclera is not visible. When there is forward bulging of the eyeball, there is upward displacement of the upper eyelid and downward displacement of the lower eyelid. So now the upper sclera and the lower sclera becomes visible. So appearance of the lower sclera is known as the Dalrymple signs or the exophthalmos. And the visibility of the upper sclera is also known as the proptosis. So we have to demonstrate it by the way of the Nabjiga test. Up to this, any confusion, the basic pathogenesis for the Nabjiga test or basic pathogenesis regarding the proptosis or exophthalmos? Now I will show you the Nabjiga test. First is extend the neck to the extent of the 15 to 20 degree. Now we have to look tangentially through an imaginary line. The line passes through the hairline and touches the eyebrow. So we have to look tangentially through a line which passes from the hairline and extending through the eyebrow. It always comes anterior to the eyeball. So if you look tangentially, it's not possible for you to look at the eyeball. So how we are looking? First extend the neck, then look tangentially, drawing an imaginary line starting from the hairline and touching the eyebrow, and then extending anteriorly. So it never touches the eyeball, and so you cannot see the eyeball. But when there is proptosis or exophthalmos, we can see the eyeball. So here lies the importance of the Nabjiga test. Now look tangentially. If you can see the eyeball, the Nabjiga test is positive, or there is exophthalmos or proptosis of the eyeball. Second, after Nabjiga test, you have to go for the Blit-Lack test or the von Graffi sign. Now, if the upper eyelid is retracted, the levator-palpebral superior muscle will be contracted. So if you ask the patient to follow your finger movement, there are two structures. One is the eyeball, one is the eyelid. Up to this point, the eyeball is not restricted. So the eyeball will move and follow your directions. But if there is any proptosis or exophthalmos with upward retraction of the upper eyelid, then the levator superioris muscle is under contraction. So first, this contraction has to overcome, then only the upper eyelid will follow your instruction. So a definite time lag will be there between the movement of the eyeball and the movement of the upper eyelid. So a lag will be there between the movement of the eyeball and the movement of the eyelid, which is the basis for the von Graeff's test or lid lag. So lid will lagging behind the movement of the eyeball. When does it occur? It occurs as a sequelae of the proptosis or exophthalmos, in which there is upward retraction of the upper eyelid leading to contraction of the levator palpebris superioris. So the muscle has to get relaxed at first, then it will follow your instruction, or then it will follow your movement. So there will be a time lag in which the eyeball will move at first. A lag will be there in which there is no movement of the upper eyelid. When it gets relaxed, only then it can follow your instruction. So this is the von Graeff's test. Third one. Next one is the accommodation reflex. You have to ask the patient to look at a distance, at a quite distance. Now we have to bring this paper all of a sudden. So first step is that you ask the patient to look at a distance. Then you ask the patient, you bring a particular subject very rapidly in front of the eyes. Normally there will be accommodation, that is pupillary constriction and medial convergence. With severe toxicosis, there will be involvement of the extraocular muscles, and then this medial accommodation or the medial convergence by the medial rectus and the superior oblique will be lost, and the medial convergence of the eye will be lost. So it indicates there is involvement of the extraocular muscles. So first test was Navjiker test, which indicates the exophthalmos or proptosis. Second one is von Graeff's test, which indicates there is contraction of the levator palpebris superioris, secondary to the exophthalmos. Third test is accommodation test, which indicates there is involvement of the extraocular nerve. Fourth, no, maybe a sign. Can you see the wrinkles? If the wrinkles are visible, the test is negative. This is a loose fold of skin. And deep to the skin, there is the accumulation of the fat. Again, the same scenario, the oxidation of the fat, production of the glycosaminoglycan, and accumulation of the fluid. So now the skin will be stretched. And this form, the transverse wrinkling will be lost as you ask the patient to look above. So if the transverse ridges are lost when the patient is asked to look above, is lost, this test is positive, which indicates there is oxidation of the frontal area of the pad of fat, which is a sequelae of the thyroid oxicosis. Finally, the Stillwork sign. The normal blinking of the eye is roughly 8 to 10 per minute. All you have to demonstrate the eye sense, you have to narrate the patient at first, only then you can do the same, except the Stillwork sign. You have to do the same while you are taking the history by suddenly placing your fingers in front of the eye. Normal response is sudden blinking. If sudden blinking is lost, the Stillwork sign is positive. So you have to ask this test, you have to do the same when you are taking the history, and you should never describe what you are going to do. You have to bring your finger very rapidly in front of the eyes. Normal response is blinking. If the blinking is lost, the Stillwork sign is positive. So on the basis of that, you have to narrate if the eye signs are positive or the neurological signs are positive, there is a sequelae of the thyroid oxicosis. So with that, finally, your clinical evaluation part is finished. And the last part is that you have to come to the diagnosis. So for this patient, what we get, multiple nodules are there in the right lobe of the thyroid gland, and there are no clinical features of the toxicosis. Patient is in the euthyroid state, and there is no retrosternal extension. So what will be your final diagnosis? First, you have to identify if it's a goiter or it's a solitary thyroid nodule. So identify the both terminology. What do you mean by goiter? Diffuse enlargement of single or both the lobes is known as the goiter. So diffuse enlargement of right or left or both the lobes is known as the goiter. Solitary focal discrete enlargement of a part of the thyroid gland without any clinically palpable abnormality elsewhere in the neck is known as the solitary thyroid nodule. So what are the terminology? Diffuse enlargement of one or both the lobes is known as the goiter. Solitary focal discrete enlargement of a part of the gland without any clinically palpable abnormality elsewhere is known as the solitary thyroid nodule. So what is the finding? Is it STN or goiter?
It's a goiter. This is diffuse enlargement of right
Goiter.
side.
Okay, very good. So first you have to identify it's a goiter or it's a STN. If your diagnosis is goiter, next will be assessment of the nodularity. Having nodule or without any nodularity. So for this lady, we are having multiple nodules. So what will be the nomenclature? If no nodule is there, we call the colloid goiter. So if the goiter having no nodularity, we call the colloid goiter. If the goiter having multiple nodules, we call the multinodular goiter. So what will be the next diagnosis? Colloid goiter or multinodular goiter?
Multinodular goiter.
Very good. Next step is the assessment of the toxicity. So what will be the next feature? Toxic or non-toxic?
In
For
this,
this lady, is it toxic or non-toxic?
in this patient, it is non-toxic.
So non-toxic multinodular goiter involving right lobe of the thyroid gland. Additional two features: with or without retrosternal extension, with or without underlying structure compression. Male or female, age of the patient. With retrosternal extension or without retrosternal extension?
Without retrosternal extension.
With compression of the underlying structure or without compression?
Without compression of underlying.
Without compression. Female patient, 40 years of age. So give me your final provisional diagnosis. Non-toxic multinodular goiter involving right lobe of the thyroid gland without any retrosternal extension and underlying structure compression in a female of 40 years of age. So your provisional diagnosis is non-toxic multinodular goiter involving right lobe of the thyroid gland without any retrosternal extension, without any underlying structure compression in a female of 40 years of age. Clear?
Yes.
Now, if the patient is toxic, then you have to classify primary toxicosis or secondary toxicosis. So suppose this lady is having the features of the toxicosis with prominence of the cardiovascular signs and the toxicosis is present since the appearance of the goiter. So what will be your final diagnosis?
So it has to be toxic multinodular goiter then, involving right lobe.
Toxic multinodular goiter involving right lobe of the thyroid gland with predominantly cardiovascular primary toxicosis in a female of 40 years of age without any retrosternal extension and underlying structure compression. Clear?
Yes, sir.
I think for today it's good enough. Just come to the clinical diagnosis, and in the later part we'll have a discussion regarding the further management. Any query or any confusion, just ask me. Any query or any confusion?
So in an exam, in this patient, what would be the case summary? How would we write it? Suppose it is a non-toxic. Like in the end, we'll have to give a case summary of this patient. So will we expand on this?
Came to hospital today with a chief complaint of painless, gradually increasing swelling in front and right side of the neck for the last 2 months or last 2 years. The patient on history doesn't give any evidence suggesting of thyrotoxicosis or hypothyroidism. Renal service unremarkable. On inspection, we get a 5 by 6 centimeter globular swelling involving right and anterior side of the neck, which itself is moving up and down with deglutition without any concomitant movement with the protrusion of the tongue. The skin over the swelling is healthy. There is no arterial pulsation or venous turbulence. The lower margin of the swelling is well delineated about 2 centimeters above the suprasternal notch. There is no associated swelling suggesting of cervical lymphadenopathy. On palpation, all of my findings have been confirmed. The swelling is non-tender, consistency is soft to firm, without any localized or systemic rise in the temperature. The coccus test and the belly sign are negative, and I can insert my finger between the lower margin of the thyroid gland and the suprasternal notch. The direct percussion over the manubrium sterni is not dull, rather resonant, and the Pemberton sign is negative. Regarding assessment of the cardiovascular and neurological status, all the findings are negative, so patient is in a clinically euthyroid state. So my provisional diagnosis is right-sided multinodular goiter involving right lobe of the thyroid gland without any evidence of toxicity in a female of 40 years of age, without any retrosternal extension and underlying structure compression.
Okay, thank you, sir.
Okay. With that, we come to the end of this session, and hopefully we'll come to another session with some other topic. Okay?
Yes, sir. Thank you, sir.